Very good morning, and thank you, WCI and Tata Hospitals, for the invitation. Now, in 10 minutes, I'll try to take you through this difficult and challenging disease called melanomas of the genital tract. The topic given was, are they different? I would say they're not only different, but they're also challenging. Now, when we talk about genital tract, you think of vulvar melanomas and vaginal melanomas, and you know that technically they're very different disease because vulvar melanomas arise on the skin and they are as such treated like melanomas of the skin. On the other hand, the mucosal melanomas are treated a little differently. If you try to see how do you stage a mucosal melanoma, actually, except for the head and neck region, we don't even have a staging system. And the reason I've put up this staging system here is to again highlight another point. By the time a mucosal melanoma is diagnosed, it's already a stage 3 disease, T3 and beyond. There is no T1 and T2 in this disease. And by the time it reaches the lymph node, it is staged as stage 4. And in stage 4, you have an ABC. So when you have that kind of a staging system, you know that this is the outcomes are very dismal. And it also, the reason why the outcomes are dismal is by the time we diagnose them, about 50% of them already have nodal involvement, and 20% of them already have distant metastatic disease. Sometimes if you read guidelines, you will see that these genital melanomas are also clubbed up with anorectal. So AUG guidelines, ano-urogenital melanomas. Now, why we study them together, I think is because not only the proximity in anatomy, but also the outcomes. Even for anorectal melanomas, if you see 5-year survival is only 2.5 to 20%. So much so that, a melanoma in that site will involve an APR. And even after APR, the outcomes are very bad. So even in our MDTs, the surgeons would actually not jump in and do an APR for a disease like this, and they would at least want disease to be stable for a few months. There is also some reports saying that even if you do an APR as opposed to a local excision, the outcomes are same. So I'm jumping from one side to the other is just to highlight that because of the rarity of the disease, we'll have to look at data from all the three sides, head and neck, AUG, and then try to see what is applicable. In our understanding of this disease as opposed to cutaneous melanomas, we still do not know what are the risk factors, right? There is no clear pathogenic role of any chemicals or any viruses. Now, so surgery remains the gold standard of treatment of this disease at any site. And after a good surgery, do you need radiation therapy? Now, to answer this question, again, we need to look at the head and neck site as an example. There have been a lot of studies, including a recent ESMO poster, 300 odd patients. They all have shown that local control definitely is better. And if you look at the numbers, 30% versus about 60%, 60% with RT, 30% without RT, but it does not impact overall survival, and it comes with toxicity. And the toxicity we know because these sites are usually urogenital or head and neck. It is difficult to deliver high doses of radiation. Melanomas were always considered to be radio-resistant disease, but with some new technology like carbon ion and the newer things, which I'm not the expert, you can even reach up to 74 grays, and they have shown that it may be better. So with respect to adjuvant radiation, the guidelines say that do not use adjuvant radiation, and unless if you are in a situation where you have not achieved a margin or you've left a gross disease behind, then you could try to go up to 45 grays, and routine involvement of the regional lymph node is not standard practice. Now, if you're not going to do, if radiation doesn't improve survival, does immunotherapy improve survival? That's the next question we all ask. We ask this question because we know in cutaneous melanomas, the results have been quite good. And if you see guidelines, they would say you should consider adjuvant radiation, adjuvant immunotherapy, and a lot of this is actually extrapolation from other studies. But is the data really that good? If you look at, there was this, again, recent ESMO poster, 157 patients, of which 27% were mucosal melanoma, 26% were mucosal melanomas, and 7% were resected stage 4. At a median follow-up of about 18 months, 71% recurred. Only 22% could complete the adjuvant therapy. So while you are treating them on adjuvant therapy, a lot of them are recurring. So the conclusion actually the authors made was, is it actually useful, right? So my conclusion is that at the moment we still cannot strongly recommend adjuvant immunotherapy for mucosal melanomas. Now, if you can't do it adjuvantly, does it make sense to use neoadjuvant? That's because, I mean, why are we so putting all our money on immunotherapies? Because we know it works. We've seen it work in advanced disease. So this is again a 36 patient data where again 53% were anorectal, 25% were urogenital, and they showed a response rate of 47%. 3 had CR, 6 had progressive disease, and the 3-year event-free survival was about 30% and 3-year OS of 55%. So it looks, maybe it may work in advanced, maybe node positive disease, maybe large surgery, when you have to do a large surgery, it's better to try that. What do the guidelines say? Guidelines again currently do not recommend adjuvant immune checkpoint inhibitors. And there's a last line saying you can consider if you think there is a high risk of relapse. So maybe a node positive or a extended surgery, that kind of a patient. There's some data of use of chemotherapy, but then again that comes from head and neck site. It's a Chinese single center study. They also have done a phase 3. It's not yet published, only in the presented. But currently, I would feel this is not standard till we replicate this and we see it in different countries. Because this is like a single center recruiting so many patients. There is something not very. This is not what we expect. So that is adjuvant. Now, when we're dealing with advanced disease, unresectable or metastatic, can we do immunotherapy here? What is the outcome with that? Now, we all know that we don't have mucosal specific trials, but then in this Checkmate 67 trial, they did include some mucosal melanomas, and what you see here on your right side is the data on mucosal, and on the left side is the data on cutaneous. And you see here the results are not as impressive as cutaneous, but nevertheless they are not that bad either. The median PFS improved from to about 5.8 as opposed to 2.6 months. And when you look at the overall survival, the median survival was 12 with EP. I mean, you can, because EP doesn't work that well, so you can say placebo was 12, and Nivo was about 20, right? So not as great as what you see in cutaneous, but still you have something to discuss. There is a combined pool analysis, and they showed that in advanced disease, you expect a response rate of about 23%, much lower than what you expect of 40 to 60% in cutaneous melanomas. And most of these patients had high volume disease, high LDH, and so. There's also some data from extended access program of EP-Nivo, and this is all the melanomas, and you see the middle line here is the cutaneous, the mucosal melanomas, which is, and here is the uveal, which is the doesn't respond at all. Now, we're going to talk about genital only. So this is the only paper poster I could find where they looked at genital versus other sites, and as you can see here, they all behave the same, at least in terms of the current outcomes. There's this drug called a LAG3 inhibitor called, which is relatlimab, and what I'm trying to show you is in a subgroup of mucosal melanomas, it did not make much difference. So in summary, immune checkpoint inhibitor can be considered. And moving on to targeted therapies. Now, if you look at targeted therapy, what targets do we usually see in these sun-exposed melanomas? And the common targets, if you see here, are the KIT, NRAS, BRAF, and if you look at in terms of incidence, the commonest would be KIT followed by NF1, then GNA, NRAS, and BRAF. And if you even amongst these mutations, it matters where the mucosal melanoma is from the vulva. KIT mutations are where almost at 35% here, small numbers, but 35% here. Vagina was, NRAS mutation was pretty common, and in vulva again, BRAF mutation is about 9%. Now we know these mutations can be predictive. At the moment, we don't know whether they are prognostic. Just briefly, I would like to mention, if you have a conjunctival melanomas, the BRAF mutation rates are very high, 40%. And this is what you should consider. Imatinib is a drug which can be used to target KIT mutations, and as opposed to GIST, here the exons you need to look at is exon 11 and exon 13, and if you look at the response and the PFS, these are quite good drugs. I mean, if you have a KIT mutation, your first drug probably should be imatinib and not immunotherapy, or I say that because the numbers they look pretty good. Now, also, in addition to KIT and BRAF, BRAF again is rare, it's not so common. As there is another paper where they looked at CDK4 amplification and they tried CDK4/6 inhibitor. Recently, people know that TKIs can work, immunotherapy can work, so they are trying to combine, and then there have been a lot of combinations, as what we do in renal cancers or hepatocellular cancers, and they all have shown maybe better results as compared to immunotherapy alone, but these are still early days. So that's my last slide. Just concluding, in addition to immunotherapy, what all you can do, and in conclusion, so the take home is that these are rare cancers, they're usually present late, surgery remains the gold standard. Adjuvant therapy, at the moment we don't have anything extremely good looking. In advanced stage disease, depending on the site, depending on the mutation, you make a choice between giving them immunotherapy or a TKI. And even with all these things, the outcomes, the 5-year survivals is not what we would expect for our patient. Thank you.